All right. Hi, everyone. Thank you for coming. My name is Nisha Almeida. I'm a epidemiologist with the Health Technology Assessment Unit of the MUHC. And today I will be talking to you about the role of health technology assessment in translating evidence into policy. So, just before we dive into the nitty-gritty, for the uninitiated, what is health technology assessment? Well, basically, it's really the process of evaluating the value of any health technology or medical technology in a healthcare system. So, be it at a country level or at hospital level. So, it's pretty straightforward and, a little more involved than a coin toss. But when you think about it, it's what exactly goes into the value of a health technology assessment. How do you assess value? And that is basically going to be the crux of my talk. So what is a medical technology? Again, has a very wide definition. It includes anything that impacts health or healthcare. So it could be prescription drugs, it could be devices, so anything from the fancy like robotic surgery all the way to the humble, pinprick needle. And it includes diagnostic tests as well as an entire organizational system. So all of these can be evaluated under a health technology assessment. And the overarching goal is really to ensure optimal resource utilization given our current climate of limited resources while still maintaining a high standard of patient healthcare and healthcare delivery. Inevitably, if you're going to invest in a resource-intensive technology, you are going to divert funds away from more important or from other services. So why is health technology assessment needed? Well, we all know that prescription drugs require rigorous testing before they are approved, and even then we have unsafe drugs making it onto the market. But for medical devices, we are nowhere near that level of testing, and it's not completely, but it's pretty unregulated. And just last week, there was an article in the New York Times detailing these serious concerns with the lack of oversight with medical devices. So, you can imagine that this is a concern because medical devices, everyone in this room has been affected by it. For example, people who need pacemakers or defibrillators. There was a recall just with the lead for this defibrillator. It affected 268,000 people. And that's not just, resulting in adverse events for those people. It's also the recall itself requires removal and complications, and so this is this costs hundreds of thousands of dollars just for complications and adverse events. And so, what's the role of someone like us? Health technology assessment basically a health technology assessment unit would be a gatekeeper, right? They would ensure that devices that have been approved by Health Canada or the FDA but have unproven safety or effectiveness don't enter into routine care.
So, are you then in a contract with the MUHC that says that the health technology assessment will evaluate devices used at the MUHC?
Technically, anything that wants to be implemented, like any technology that wants to be integrated into the MUHC should come through us. But does that happen every single instance? No. So who we are, thank you, Teresa, is we are the Health Technology Assessment Unit, or TAO, of the MUHC. So we are an advisory group that assists the administration in making these decisions, which medical technologies and health interventions should be integrated into the hospital, and we use the best available scientific evidence to do so. So Nandini sitting over there is the director of our unit, and we consist of a research team who performs the health technology assessment, and then we have a policy committee who makes the final recommendation. So the committee represents physicians, nurses, patients, and the hospital administration. And we can issue three types of recommendations. So if the evidence for the overall assessment is strong enough, we approve the technology. However, if the evidence isn't sufficiently strong, but is suggestive that the technology may be useful, we issue an approval for evaluation. Now, what this means is that it's a temporary approval, conditional on various criteria, and it's implicit that we will eventually reevaluate the technology, especially if new evidence becomes available. And then finally, you have technologies that are not approved simply because there's no evidence or the evidence is too poor to recommend approval. Sure.
So the evidence is versus evaluation. The evaluation is positive and
yes.
That must be quite rare.
Actually, not really. In fact, for both of those top two, the institute funds the technology. It's only in cases where we recommend that the technology is not approved, and then no, not the evaluate. No, it's the use of the technology. Well, so technically that the clinicians themselves would collect data. So the idea is that we're going to say that yes, you are allowed to use this, but there'll be different criteria saying maybe not more than 10 people or not for more than 6 months. But they have to collect the data, and then we assess outcomes. And so technically this should be done within a fairly short period. Basically, yeah, the institution, so the department themselves, which is, has this comes up all the time because departments say that they have limited budgets to do that. So. Yeah. Yeah, exactly. Well, we certainly haven't had any that have gone from approved for evaluation to not approved. I don't know that any. Yes. Exactly. I mean, often we just ask that sometimes it's just, yes, collect the data that we need. So indicators, like for selection, like how are you selecting these patients? Who's getting it? Because often we don't even have that basic information. But often it's just outcomes, like are you collecting survival at discharge, for example? Some things that, because long-term outcomes are very hard for the hospital to do at this moment, but anything that can be done within the hospital, more and more departments now have at least some structure in place to collect these data.
How do you decide which products or which devices or technologies to evaluate?
So we at this point are not the ones who make that decision. Usually we are approached by a clinician or even the administration and asked to look at something that has evoke their interest. It's something that's new. Yeah, anyone. And it could be anything. So even like software example is something that can be evaluated. So our HTA process, basically is you receive a request and we then formulate a policy question. For example, should we use probiotics in hospitalized patients who receive antibiotics for the prevention of CDC-associated diarrhea? That was an actual request. And so what we do is we collect the evidence. The evidence can be published literature, gray literature, or even local data if they're already using this technology. So this technically should then go into the decision-making process, which informs our final recommendation. But what exactly is the decision-making process? And, that is what we are trying to figure out. What goes into the decision-making process? How do we evaluate the value of this intervention? So there are three big players. Effectiveness, like would probiotics be effective in reducing diarrhea? Is it safe? And what's the cost of integrating this intervention? But are these three enough to inform the final decision? So now here at the TAO, we have not had a definitive list of criteria that we consistently evaluated each assessment. And so, Nandini said, being scientists, it behooves us to perhaps have a more systematic approach to this process. So before we dived into collecting and all of the criteria, we did this little experiment to understand whether those three factors, efficacy, cost, and safety, are really just sufficient to inform your final decision.
Now you said effectiveness before, not efficacy.
Okay, I'm using it interchangeably, Teresa, but
Really?
but fine, let's go with effectiveness because we don't have enough RCTs. Often we don't have RCTs to inform us of a decision. So what we did was we reviewed 24 of our reports and we tried to correlate the overall strength. So we created this composite measure of our three factors and we correlated this overall strength with the final recommendation. So what you have here is on the x-axis you have the three types of recommendations that we make, and the colors are the overall strength of efficacy, cost, and safety. So if it's red, it means that those three factors were really weak and did not favor approval of the technology. And when it's green, it's the opposite. That means all three were really good and favored the technology. What we see here, like in this part, is that we approved reports where one of them had, weak cost, effectiveness, and safety, yet it was approved. And on the far right, we have reports that were not approved, and two of them actually had strong effectiveness, cost, and safety. So clearly, these three dimensions aren't exactly the only factors informing a final decision. There are other factors that go into it. So now we aren't the first people to ponder this question. Like there have been other frameworks. GREAT, most of you may have heard of it, did also come up with a framework for making recommendations. But, these are a good starting point, but they're fairly vague. I mean, what does it mean, balance between desirable and undesirable effects, or consistency with expected societal and ethical values? I mean, they're good concepts, but how do we integrate this into the decision-making process? And second, these are frameworks, for decision-making in general, but they don't quite apply to a hospital-based health technology assessment unit because we have other factors that should go into the decision-making process. So that, launched us into our odyssey of the decision-making process and how to come up with a tool. And so our overarching goal really was to create a structured and transparent decision aid tool. So something that would be user-friendly and simplistic. But, something that would also ensure that we are giving consideration to all the factors that should shape the final recommendation. Which one?
All the domains should be given equal consideration.
Not equal consideration, but you should be able to consider them at every single time.
So you don't mean equal consideration. You
No.
mean consideration.
That's right. That they should be. You should think about them.
Because
Yes.
I think that some of them are more important than others.
And herein lies the subjectivity of this whole topic.
And it's called flexibility.
Yes, but I mean, the issue is that you want to make sure that you're thinking about it, because often you look at a report and you're said, okay, I take the point there. No. And then it's something that would improve transparency, right? You want to make sure that every time you have a factor that goes into the decision-making process, you're documenting it. And, you want a tool that can be applied in a systematic fashion. So this improves reproducibility, right? You know exactly what went into making the decision when you go back and look at that report. So our objectives are fourfold. One, to identify the relevant criteria. Two, to determine their importance as determined by an expert community. Three, incorporate these into a decision aid tool. And then four, to illustrate the application of this using an example of ours. So how do we go about identifying the criteria? Well, first we used OTAC, which I had just previously mentioned, just to give us an idea of the global domain. So, they had mentioned clinical benefit, cost, feasibility, and ethics. And we also then looked at our past reports to give us an idea of what was shaping our own recommendations, because this gives us an idea of the factors at a hospital-based HTA. And then we also reviewed the literature to gather more domains. So this is, a first draft of our list. So you have clinical benefit, so your usual effectiveness and safety. These pertain to cost. This pertains to the feasibility of implementing a technology at the hospital. And then this section is called ethics and values, because there's this enormous emphasis today to incorporate ethical considerations and societal preferences into decision making. And so it's a fairly nebulous concept, and we identified these factors. For example, disease is rare. Does a disease being rare preclude us from evaluating a technology that focuses on that disease because of its possibly low cost effectiveness? And then we looked at strategic considerations. So anything that would strategically impact our institution, like ability to attract clinicians, researchers, patients, how innovative this technology is, creating research opportunities. So once we identified this list, we decided we wanted to find out, how important does the expert community consider these factors. And so we conducted a survey using members not just of our community, but also outside of it. And the idea was to determine the importance of these domains, to also solicit any other factors that we may have missed, and also collect information on the MUHC values and preferences. And so in the survey, we asked each respondent to rate the importance of each criteria on a 5-point Likert scale, so going all the way from not at all important to being indispensable to the decision-making process. And so we sent out the survey to 61 people, of whom 52 responded with complete responses. And the breakdown was the vast majority were MUHC members. A third of them were members of HTA communities, and 23 were administrators. And the idea was to try and get a diversity of viewpoints, because administrators and clinicians don't necessarily have the same idea of what criteria, how important a criteria is. Because it's not exclusive. Because MUHC members can also be administrators. So this is our results. It's a radar plot, which basically shows the percentage of respondents considering each criteria either important or indispensable. So, any points on the circumference on the periphery would indicate that most of the respondents consider those criteria important. So you have your usual suspects: effectiveness, quality of the evidence, safety, cost, hospital efficiency, patient-important outcomes. The vast majority of people consider these to be important. But then factors such as external financial support for the technology, prior hospital experience, the impact, the ability to attract new patients or professionals didn't garner a lot of support among the respondents. So this basically is it shows you the same information as the graph, but it also shows you consensus. So basically, all the criteria highlighted in green indicate that the vast majority of people agree that these were either very important or not important at all. For example, external financial support, 80% of people thought that it wasn't important. But then here, the red one, that's where we received a diversity of responses. So people, didn't agree, so we didn't have consensus on whether these were very important or not. For example, the disease is rare. About 54% of people thought that yes, this is extremely important and should go into making a decision. But then we got a lot of comments saying, well, the MUHC is the mission is to treat all diseases, and so just because the disease is rare, it shouldn't really be taken into consideration in the final decision. Yeah, I think it was 80%. So anything that was a little less, like here, this is on the threshold. Yeah. But then here we really received a diversity of responses. So, with some people saying it's,
So you kept all the reds.
Yeah, so basically we didn't drop anything. We wanted to get an idea of how the community felt, but we kept everything. And so, what we did was we reorganized our domains because, as I mentioned, ethics and values was a nebulous concept, and that was very clear from the feedback we got because it was hard for people to, pinpoint what exactly are the ethical considerations in these criteria. And a lot of people said that, these also are pertinent to other domains. For example, the impact on patient was something that was brought up many, many times, and so we created a separate category just for that. And we also created a category for impact on healthcare system because the hospital doesn't really work in a vacuum, and so any decisions made here does have repercussions on the healthcare system and on society in general. So we looked at that, and then we decided that ethical considerations would be something that yes, we would have to consider at every assessment, but it's context specific. So we wouldn't have a specific factor that we would look at, but we would have to take it into account every time.
I'm surprised that you dropped the values from your ethical category, and I think that values and preferences of people are really quite important. And for example, WHO, ethics and values on the left-hand side is now changed to ethical considerations on the right.
No, we have spread this around. But basically, what it means is that we didn't think that the title made sense. So we did keep a lot of these. No, but the problem was that we couldn't put our finger on what defines ethics, and so the idea was that we have to keep these criterion, but not put it under the umbrella of ethics and societal values. We would have more specific terms that spoke to the people more, because when you ask me what is an ethical consideration, I'm not entirely sure, which way it goes. But no, we didn't drop anything. We distributed it. So we do have that as one of the criteria. So it's a little more specific. We look at patient values and preferences. So something that we would then, be forced to actually assess, as opposed to with being a little more nebulous and saying, it could go anywhere. So finally, our third objective, not finally, but so the idea now is, okay, we have our list of criteria and we have determined their importance. What do we do with this list? So we had to create a decision aid tool, and we decided to have a 3-step process in the way it's implemented. So in the first step, the TAO researchers complete the health technology assessment, and then they record their findings. So don't worry about the minuscule text. This is just for illustrative purposes to say that they would then fill out this column of the findings for each criterion. And then they would rate their findings. So they would answer the question, do these findings favor the approval of the technology at the MUHC? And they would have four options. So yes, no, maybe, and need more information, and it would be color-coded. And then we would send this tool out in the second step to the policy committee members, who would then fill out the column on the right. So they would be asked to rate the importance of each criterion based on their own opinion and also within the context of the technology. So they would have the option of choosing between very important, somewhat important, and not at all important. And again, this would be color-coded because the idea is, all these garish colors, we used it to provide a visual means of arriving at a final recommendation. So basically, we want to juxtapose the importance rating against the finding from the evidence. And so, when you look at this, you fill out your tool and you look at this and you say, okay, all these green ones, I consider them to be very important. So if I want this technology to be approved, I would want to see green on this side too, which would mean that the findings were favorable. So, for a technology to be approved, the majority of criteria that you considered important should also have received favorable findings. If you still think that the technology should be approved, then you need to provide your extenuating reasons for this, and so that would be documented. Not the administrator, so it's the policy committee. Yeah. Yeah. So this has been an issue where we're trying to debate how to go about this because we had considered sending them, just the list of criteria and then please rate the importance before the start of the health technology assessment, so then they're not biased by these results. But then we have to balance there's a trade-off between how much work we want them to do and we want them to get it out there. So yes, they get the findings.
Say we actually go through all of the outcomes. Like we can talk to Carla, say the mortality of important, less important, cost. They rate all of these as important, less important, not important. Then later,
Yeah, so our reasoning was that if you get a list of criteria, you're always going to say yes, effectiveness is important, safety is important. But within the context of the technology, often you may not even be assessing safety of a certain technology. So in that context, it's not important. And so I felt that, we felt that having the background of the findings and the technology would impact on how you rate the importance. Yeah. So that was, yeah. Yeah. Well, they still have to, actually, because the policy committee has to read our actual whole report, which they don't. But, the idea was, if we give them this, then they're reading the finding. But, our other option was to send them the research questions, detailed it and say, okay, within the context, rate the importance. But then in step 2, we would actually still send them this and say, these were your, importance ratings from before. And now make the decision, because they still need to see both colors to basically come up with the final recommendation.
So I have a question about content. So do you send this to content experts or just people? Like your health administrators? If you have a cardiology device, do you send this to cardiology people or do you send it to the general medical personnel or whatever? So I'm really concerned about people here that participate in this evaluation do they really understand what the device is and what the talking about?
So at the policy, the committee members also include the requester. So that person comes to the meeting and can make the case. But then all of the other committee members, they are clinicians or but they won't always be experts in that.
Because I think that is an issue actually in some instances.
But so that's where the report comes in, right? So our report, if they read it, would really detail the technology and then really all the other aspects of it. So hopefully it would answer any questions they have.
But any community representatives or any patients ever involved?
So our policy committee meeting, a policy committee has a patient representative. She's meant to represent.
Yes. No, I'm just curious, even in terms of creating the tool and sort of, clearly it seems like it's fully from the user's implementer's perspective or not.
But during our survey, we actually did have patients as well take the survey. So we wanted end users as well, because all of us are users of health services. So we did have people who are not clinicians or MUHC members take the survey as well.
I would have thought that in that patient values and impact, you would have obtained the feedback from the patient community, not just one person.
Oh, okay, right. So that is something so this is new, right? We haven't yet implemented it, but the idea is, and that's not something that we have ever done, is to get the patient perspective, and that is something we would have to work on, like to try and do a survey of patients and how they're feeling, values and preferences. Right. Yeah. So these are all the patient outcomes. Clearly, we are lacking in that aspect. But it's something, we thought was important, and so it's something we will develop. So the final step, we convene the policy committee, and we present them the aggregate results. So basically, the aggregate importance ratings as well as the final recommendation it could be something like this saying 69% approved. But the idea of this meeting would then really be to focus on those criteria that that cause dissent. So instead of spending time just discussing everything, we would focus on extenuating reasons until we reach a consensus. So this part of the process is to build consensus to come to your final recommendation. And so here the idea is everything would be documented, so it's transparent and structured. And then just a side note on why we didn't use quantitative methods. Others, again, have come up with frameworks, and the most often used is the multi-criteria decision analysis, which basically is a tool to take your evidence and your subjective values and then create a numeric score. So that's how they translate the evidence into policy. And so very briefly, what they do is they take your, on the far right, that would be your values and preferences, they give it a weight. And the weight is based on a survey of people, and it's also a relative weight based on all of the other criteria. And then here in this column here, this is your evidence, so they give it a numerical score. So for example, yellow would be 1, red would be 0. And then they use a variety of models to combine those two and give you a numerical utility measure. So, they would have a measure for this intervention versus the alternative, and you have an actual objective number, which tells you, yes, I'm approving, no, I'm not approving. Now, the reason we didn't go down that route was because we felt that it's hard to quantify subjective values, and further, all those weights, they are specific to the population. So if you're surveying, patients, you're going to get different weights. If you're surveying clinicians, you're going to get different weights. And also it's context specific. So, as I mentioned earlier, safety may be important in general, but it may not be specifically important to a certain technology. And so we felt that it was impractical for our users, and it's also a very user-heavy, user-intensive method. And we wanted to keep something to be simplistic and encourage use. So our last objective was to go through an example to see how this tool works. And we chose ECMO, or extracorporeal membrane oxygenation, which is a report we just completed. And so for those who don't know, ECMO is a very resource-intensive technique that circulates your blood outside the body, oxygenates it, and then retransfuses it back into your body. And the idea is to keep you alive if you're suffering from cardiac or respiratory failure. And it's resource intensive because it requires, at least at the MUHC, the presence of a perfusionist 24/7 at the bedside. And ECMO patients can be on ECMO for anywhere from 3 days to several weeks. And so our policy question was, should ECMO be routinely incorporated at the MUHC to support adult patients in cardiac failure? So ECMO, has been used for respiratory failure, but we were looking at cardiac failure in adults, and we were looking at 3 distinct populations. So you had patients with cardiogenic shock, so that happens usually when they're in surgery and happens in the OR. Then you have these two, which are cardiac arrest in the hospital and out of the hospital. Now, here, the use in these populations for ECMO is fairly new, and it's called ECPR because these patients come in with cardiac arrest, you initiate CPR, and then you determine whether they go on ECMO. And so those were the populations we looked at. And these are some of our results. So as you can imagine, it's kind of hard to do an RCT in this population. Like the logistics of, determining who gets a cardiac arrest and then how you designate them to ECMO or not is complicated. And, what we found was very few studies, and they were all observational. And this is looking at ECPR, so patients with cardiac arrest in and out of the hospital, and the comparison group was just CPR, so they're basically getting manual compressions. And what they found was, it seems like a tiny little suggestion that there is improved neurologically intact survival, because a lot of these studies just looked at 30-day survival, so survival at discharge. But survival is one thing, but if you're not neurologically intact, then really, what is your quality of life? And so there's a tiny hint of possibly improved neurologically intact survival, but the quality of the evidence was absolutely terrible because, imagine these studies, anyone being put on ECMO, that's a spur of the moment decision made by a clinician, and it's, the reasons for them being put on ECMO completely differs from for patients not getting ECMO. So these two populations are entirely different. Are they comparable, and will this affect your results downstream? Safety, you just saw that picture of what ECMO is. It's an extremely invasive process, so you're going to have a high rate of complications. The cost, what we did was we calculated the additional cost of a patient staying on ECMO. So assuming that the patient who didn't get ECMO survives and goes to the ICU, we calculated the cost of them receiving ECMO. So this includes perfusionist time, etc. And we found that to be around $30,000. So we have survival rate up to 30 days, and covers about 50%, like around 40%. From our studies, so each study had around like 50, very small numbers, because again, the logistics of getting these patients is not easy. So the availability of local expertise. Now, the concern for us is that we just didn't, the MUHC has a limited number of perfusionists who perform a variety of services. They need to be in the ER for cardiac surgery. And then with ECMO cases going up, they're often diverted away from those surgeries, which basically means those are elective surgeries which are bumped. and so you have waiting times. It really creates this whole backlog. Not to mention there's a burden on perfusionists because they're working overtime. Overtime means extra costs for the MUHC. So, we had that issue as impact on resources. There's this huge increase in time perfusionist hours, which has this snowballing effect. However, there's the innovativeness of ECMO. If you have a cardiac arrest, do you want CPR or do you want this awesome fancy sounding ECMO thing which may keep you alive? It has the impact. It has an ability to attract patients or attract healthcare professionals who are training in this technique. The number of effective patients is potentially very high because cardiac disease is a number one factor here, and cardiac arrests are treated at the MUHC in increasing numbers. And then there's the stakeholder pressure in that ECMO is being increasingly used outside of cardiac surgery to treat cardiac arrest patients who are coming from outside the hospital. So
This is a good example of a very complex technology where it seems like a big part of the cost is using it, not necessarily the actual technology. So when you evaluate these things, you kind of break it down into, I get it, there's a machine and there's certain things that really need to be sold up to that cost. From the perfusionist, that every center has the same policy, or is that really a local policy that then drives the cost? Never mind, this is an example. Like how do you break out elements?
It's very institution specific. That's what we have noticed from almost any device that we have looked at. Because, you mentioned device cost, which you would think would be universal across Quebec, but it isn't because, they put out biddings and go to tender, and so every institute can end up with a different cost for their device that they end up using. So it is institution specific in the end. And again, perfusionists, every institute has its own policy. So this at this point really pertains to our institution and how costs are spread out.
Technology, however, the components of the really driven by policy are
right.
rendered as much more complicated than ever.
And so those are recommendations we do make. When we say that if this is being driven by the number of perfusionists, then our recommendations are what are the solutions you're looking at, and the MUHC is currently looking at training nurses to replace perfusionists, for example, so that way it cuts down on both burden and cost. And those are recommendations that we make in our report.
Okay, so can you take into consideration the fact that sometimes this technology is being thrown in as a pre-growth for a pretty particular indication, but because now it is more available, then it will start to be used on people that this happens all the time.
Yeah.
As it is happening at home right now. So how can we kind of take that into consideration now that people have access to the technology, but that's not right?
Yeah, so it's called technology creep, right? And so what we try to do in our recommendations is say that, yes, please just use this for only this indication. It's not indicated. Often, if we do evaluate various different indications or populations, we'll say, there really was no evidence for this population, so it's not approved for use in this group. And then we send this to the administration and they make the final decision. But what happens during clinical practice is really often out of control. This is our issue with ECMO. It's already at the hospital. You can't tell the clinicians don't use it on, cardiac arrest patients, because if they have it, they'll use it.
A similar question. Is a 19-year-old the same as a 20-year-old that comes with cardiac arrest?
And that was our other what we evaluated was what are your selection factors? I mean, this is the issue with ECMO being used for cardiac arrest, is that right now they haven't developed one, and so our recommendation was please, make a list every time you treat someone. How did you select these patients? What were the criteria? And then we will hopefully be able to evaluate this. The good news with ECMO is that at least they have a database in our hospital, and they are, following outcomes and recording it. So that's a step up from other. Right, no, selection factor. Yeah, we did, I think, also ask. Yeah. Yes. So, I just wanted to go through this with you guys now, actually. So pretend that you're all policy committee members, and I haven't put in the entire list of criteria, but I've chosen those factors that I think are the most important in arriving at that decision. So if knowing what you now know about ECMO, you're asked to rate the effectiveness of ECMO in improving urologically intact survival. How would you rate it? Very important, somewhat important, not at all important. Yes, I'm asking you. So just throw out answers. Very important. So I'll just fill in the color. And then what about the quality of the evidence pertaining to this particular context? No, but how would you rate it? Yes, the quality was 4. Is it very important? Okay. Safety? Very important. Yes, definitely in this case. Cost. What's the issue? Yeah. I mean, like, the counterfactuals are difficult. Mustard yellow, is that what we're going with? So what's the safety? Mustard yellow. Okay. So cost? No. Not important? Red. Oh, come on.
Where it comes down to risk benefit versus cost benefit. Risk benefit should drive the individual clinician. Say, it's too risky, I'm not going to do it, fair enough, or I think the benefits outweigh the risk. And the hell with the cost.
Well, see, that has been our clinicians' perspective. They're like, how with everything, we're using it because we have to. But also, what you brought up is also, it's a spur of the moment decision. I mean, we're sitting here in a room saying, yes, can you please consider these lists before you give someone ECMO? But, they're just, the patient is dying, he's dead already, and you're saying, how do I, should I do ECMO or not? And that has been an issue. Yeah. Right. We're seeing this from the policy perspective. Okay.
Someone says, look, this is too expensive, we don't have it in MUHC. I said, well, they've got it over Sherman, they've got it back to Paris. I have here, but some committee said it's too expensive. Come on.
It's yeah. I mean, exactly, that's the point, is that we already have ECMO, and it's always been used for cardiac surgery. The idea, the question is, should it be used in cases of in hospital, and especially out of hospital cardiac arrest, where we don't know how long the patient has been in cardiac arrest, they come to the hospital and you're saying, yes, definitely put them in ECMO. And the issue is once you put them in ECMO, they're on ECMO. You can't say no. Like even once the team has been deployed, that's already costing. And then once they're on ECMO for that minimum amount of time that they need to be on it to see what's happening. And so it's intensive. So what was the final decision here?
Yeah, but we're not talking the same language. That's the problem. I don't think we're talking the same. So, people will be using these colors in different ways. Because there's no standard way to apply it. Yeah.
But
that's okay.
Yeah. That's exactly. This is the point. It's a value judgment. So it's your value. You put it in there, and then you make your recommendation, but based on the entire, all your criteria. And then we discuss at the meeting.
Here's the total budget, and here's all the requests for things. How are you going to triage from this framework? In policy, if there's a circumstance where many technologies are ranking really, really well, except for the cost, that seems like a scenario where you consider increasing the budget because
right.
We're not providing effective care purely due to cost.
So let's go through this, but so we didn't use this tool for when we actually evaluated ECMO, and so you'll see that our recommendations were pretty much basically what you said, was that was definitely please find some resources in your budget to, because the clinicians were adamant that they would use this technology. It was hard for us to say, please remove ECMO, and at the same time, at the same time, it was also, we're saying if you're going to use ECMO, there definitely is this, you feel that it has to be used, you need to have an increased budget, because we said that it was untenable to continue at the rate that they were reporting. But anyway, what's the decision here for cost? Red? No, it should not be red. So what color?
I think it's a maybe.
Okay. Well, wait. This is actually, this is done individually, right? Because so you would actually fill this, so there wouldn't be anyone else telling you what to do. But then when you go to the meeting, you can then see where you were versus the general, because we provide them with an aggregate. So saying, people think like 80% thought that cost was important, but then you thought that wasn't, and that's when we had that discussion. So the 20% red has to make their case for justify the reasons for why they think it isn't important. Oh no, because this is an individual tool. Then the discordance will happen at the meeting, where each individual person will say. Sorry? Yes, that's normal. Sorry, was there another question there? Right. Yeah. So often, our findings are based on the evidence and the populations that we have. No. But in the end, we don't. Yeah, we try and say these are the populations that the evidence says it works in. But then we often leave it to the clinical decision making is left to the clinician. So.
But if you're opposing it, you're something like stable, for something like the cost, is operating on the assumption that you provide them with some sort of expected frequency or number of
costs are very high, but I think
it's taken.
very reasonably.
When we calculate the cost, we have this hypothetical based on a projected number. So we say they're doing it in 20 cases per year, and so then the cost is on those numbers. Right. Yes, the policy committee members know this. Right, this is all given to them, and it's in the report saying that we used. We're assuming that only 20 people get it, but if 50 people get it, then they know what to do. Better job.
If you're only evaluating one at a time, it's kind of easy to say, well, that's not that much, great. But, you have all these different things, and when you're not even balancing against the things that are not your technology. So, if we were to do this for, we should have adequate nursing on the wards. Well, we don't really have that, so obviously we don't think we should.
That's the thing. So the cost is relative, right? So it's what 13,000 is a number, but it's when we put it out, it relates to the budget of that department. So for that department, it's 13,000, a huge amount. Can they rustle up that money?
But it's not sort of prioritized. Okay, like we did this based on everything else.
Yeah, so we don't have all. So that would be an administrative decision. We don't know what other technologies they're juggling at the same time. So we make our recommendations, and the administration, I don't know how they decide whether it's within the light of all the other technologies they're looking at. So what did we decide for the color here? What? Sorry? Striped. Yellow then?
It sort of raises the question about whether the technology assessment unit should be involved in policy at all.
Quite effective, I would say very effective. Can people regular NPR drugs for like one person better drugs? So in fact, what I see that drives the recommendation is effectiveness, quality of evidence, safety. That's what really drives the recommendation. And the activists and the patient representatives all say, we want good drugs. Find the way to get them.
Right.
And I think the technology assessment really is focusing on what's the evidence for effectiveness, what's the quality of evidence, what's the safety, usually primary safety. And I think the things that you can really have methodology contribute to great. I'm not sure arguing with the administrators.
Well, the point is that, yes, you can measure, those are easy to measure, but then there are all sorts of other contextual factors that we need to measure. Who else is going to measure them and then give that information to the clinicians and administrators, saying as, right.
But that the people around the table are the mix of people that make those decisions taking on the most appropriate. And I think the technology assessment unit evaluates technology. And I think what you are doing is you are showing how policy, you have one approach here of how policy can be used or evaluated or some recommendation to be made. But whether that should be the role of the technology assessment is debatable, I think. Anyway.
Right. It's and another talk. Yeah. The availability of local expertise. So in this case, this would be our perfusionists. We didn't have enough of those, and the fact that we don't have a designated ECMO team. So there's problems with them getting being deployed fast enough. So what would you rate that as? 3, no.
Go to the next slide. Yeah, just because we don't have all the information, so maybe you can just fill it out for us.
All right. Okay, so let's say this. Okay, I'm going to say what I think. I'd say this would be important. The impact on resources I consider to be very important. Innovativeness, say okay. Number of affected patients, I'd say is important. Stakeholder pressure, I don't think is important, but that's me. So anyway, then you look at this and you say, well, what would you do? Would you recommend this? Yes, no, maybe.
I think it's difficult to come to a decision.
Yeah, so we didn't use this tool when we made our decision, but you know, as we saw here in this debate, there's this huge clinician pressure then versus the resources used, and so we approved it for evaluation. So with a whole host of conditions, such as you need to procure dedicated funding, you need to have a designated ECMO team, etc., etc. Documentation, as you mentioned, of patient selection factors and outcomes, and hopefully, once they have something going, we reevaluate the evidence. But the whole point of this exercise is saying, would this tool help you, arrive at a recommendation in a more structured way than what we have been currently doing? So our future directions are we are going to pilot for our next report, and we are planning to use Survey Gizmo. I don't know if any of you people have ever used this, but I thought it was very handy because could you I think to control no, but the MUHC has an account. Can you control? Oh, okay, it's not doing anything. Oh, it doesn't work. Oh, it doesn't. Oh yeah. And so basically, this tool we thought it would be better than sending an Excel file. So you would see something like this, and you'd have your findings, you'd have R ratings, and then you go around and put in your color, and then hopefully you'll be able to look at this and come up with a recommendation. So the idea of using this instead of Excel was that you have all of your data in one spot, and so pretty much this is the end of my talk. I think the conclusion is that decision making is the inherently subjective process. The inimitable words of Dilbert. The question is, if making a decision is just a process, why can't a computer do it? And that's really, his boss response, because sometimes I have to rely on my gut. And what we're trying to do is kind of come up in that, strike this balance, saying we can't quantify your individual values and preferences, but we can't completely rely on your preconceived biases as well. So we need to come up with this tool that somehow takes these two different values and puts them together and helps us come up with a recommendation. So yes, the advantages of our methods is that it's simple, it helps with transparency, and it helps with the systematic approach. Thank you very much for sticking around.